So now let's spend some time to discuss the cardiac and vascular function curves. Now I remember when I was a first and second year medical student, I was horribly confused by these graphs. I struggled with them a great deal. My only advice to you to understand these graphs and to do better on step 1 is to really break them down and spend time with them. And once you do, you have to review it and review it and review it. The key to understanding these is to see them over and over again. If you just look at them once, I guarantee you will have trouble analyzing them on test day. Remember, on exam day, there's a lot of things going on. You're nervous, you're in a foreign place, there's limited time. You need to make sure that you prepare yourself well so that when it comes to that high stress test day, you feel comfortable when you see these graphs and they look familiar to you. That's really the best way to ensure that you feel comfortable on exam day and have the best chance of getting these questions right. So let's go over them together, and I encourage you to stop the video as needed to really think about the concepts, because this is a very conceptually challenging part of cardiac physiology. So now let's break down this graph. On the x-axis, we see the heart volume, which is represented here by right atrial pressure or end diastolic volume. Up here on the y-axis, we see cardiac output / venous return. So this is a little bit confusing because the right atrial pressure and the end diastolic volume don't have anything to do with each other. But the key thing is that the right atrial pressure is corresponding to the venous return on the y-axis, and the end diastolic volume is corresponding to the cardiac output on the y-axis. So you can see that these two sort of connect with each other, and that's how I sort of brought this concept together, is that they're sort of related to each other, and we'll see how that makes more sense as we continue understanding the graph. So the red line is the Frank-Starling curve, which we talked about in another portion of this lecture series. It is the cardiac output as a function of the end diastolic volume, which is the Frank-Starling curve. As the end diastolic volume increases, the cardiac output similarly increases. The blue line over here is a little less intuitive. It is the venous return as a function of right atrial pressure, and really it's a function of total peripheral venous tone. The tone of the veins determines the amount of blood that returns to the right atrium, and thus determines preloaded end diastolic volume. So if you remember, the heart is in series, so the venous return will eventually become the cardiac output because the blood has nowhere else to go. So like I said, the blue line is a little bit less intuitive, but as we'll see, we'll sort of make sense of it here. The red and blue lines intersect at this point. This is defined as the operating point of the heart. It indicates where the venous return and the cardiac output are equal, basically meaning that the cardiovascular system is just one big closed loop. Anything you pump forward as your cardiac output is eventually going to come back as venous return. So now in your first aid book and in many other physiology books, there's different graphs that have different situations that they're illustrating certain concepts. So in this graph, graph A, we're going to spend our time discussing inotropy. So now do you remember back, what do we mean by inotropy? Changes in inotropy indicate changes in the force of muscular contraction. So really it's the force of contractions, or the contractile force of the heart. That is referred to as inotropy. It is a change in contractility. An increase in inotropy means there's an increase in contractility independent of preload. This is key. It is independent of preload. We can see here that when there's increased inotropy, we see an increase in this cardiac function curve. So we can see that there is an increase in cardiac output for any given end diastolic volume. So we look at here at this end diastolic volume, say it's 500 cc's, it's a little bit high, but say it's 150 cc's as our end diastolic volume. We can see that when we have positive inotropy, we say we go from a cardiac output of 100 to a cardiac output of 200. I'm just making up numbers here. But we can see that as we increase inotropy, we increase our cardiac output independent of end diastolic volume. So this is key here, and it's shown graphically as increase in inotropy increases our cardiac output independent of preload. The reverse is true for a decrease in inotropy. If we see a decrease in inotropy, we see a decrease in cardiac output for a given end diastolic volume. Remember, anything that increases calcium increases inotropy. Calcium is the key player when we talk about myocardial contractility. Certain situations that increase cardiomyocyte calcium include adrenergic states where there's catecholamine rushing around the bloodstream. Digoxin is another inotropic positive agent. These both increase intracellular calcium by different mechanisms, but ultimately result in increased calcium that acts to increase the contractile force generated by the myosin and actin interaction. Things that we're going to decrease our inotropy include situations such as uncompensated heart failure, narcotic overdose, situations when the sympathetic drive is decreased or the muscarinic or acetylcholinergic response is activated. We can see that there's a decrease in inotropy, and therefore we see a decrease in our cardiac output. So in summary, there are situations when we have both an increase and decrease in inotropy that change the cardiac output. So now moving on to the next graph, B, we're going to look at how changes in cardiac function occur in changes in venous return in terms of the vascular function curve, this blue line here. So first, let's review a couple concepts. Venous return is equal to venous pressure, or the pressure in the veins, the blood pressure in the veins, minus right atrial pressure. This makes sense if we think about it, right? Because we're talking about the inferior and superior vena cavas with a venous pressure pushing blood into the right atrium. If the right atrial pressure is greater than the venous pressure, we're not going to see blood flow from a lower pressure state to a higher pressure state, so we're not going to see blood go from the veins back into the right atrium. So when the right atrial pressure is low, we see an increase in venous return. I hope that helps define what we mean by venous return. So there are many situations that we see an increase in venous return, such as giving somebody an intravenous fluid bolus. Now, this will increase our venous pressure by increasing the intravascular volume and thus increase the blood that is returned to our right atrium, because this difference here will be greater. So we see an increase in venous return, which is shown by our line over here, number 3. Similarly, as we call an IV fluid bolus, increased sympathetic nervous system activity will increase the venous return by causing venoconstriction, or causing constrictions of our veins, and this increase in venous tone pushes the volume, or the blood volume, back from the cavas into the right atrium and into the heart's circulation. So we see that when we have increase of volume or an increase in venous tone, we see an increase in the vascular function curve and an increase in venous return. As such, we see an increase in cardiac output for any given end-diastolic volume. So in number 4, in situations of volume loss, or in terms of loss of venous tone, such as in situations of acute hemorrhage or spinal anesthesia or neurogenic shock, we see the exact opposite of giving somebody a bolus or activating the sympathetic nervous system. In acute hemorrhage, we lose intravascular volume, which causes a decrease in venous pressure, which leads to decrease in return of blood to the heart. Spinal anesthesia blocks the sympathetic nervous system. Neurogenic shock is a result of a loss of sympathetic nervous stimulation of the cardiac tissue. This results in a loss of venoconstriction, resulting in reduce in venous pressure and a reduction in venous return. These all things result in a reduction in the vascular function curve, and reductions in cardiac output, and a reduction in mean systemic pressure. These are all bad things that our body doesn't tolerate so well. Now moving on to diagram C, we will consider the effects of total peripheral resistance on our cardiac and vascular function curves. So here again, we see the blue line, which is our vascular function curve, and our cardiac function curve here in the red line. So to remind ourselves, total peripheral resistance is mostly determined by our arterioles. If you increase the resistance in the arterioles by, say, decreasing the radius of the arterioles or increasing the viscosity, we will have an increase in total peripheral resistance. This will lead to an increase in afterload, thinking about our cardiac output variables, and this will, as such, decrease our cardiac output. Why does this also rotate our venous return curve down to the left as well? Well, it's important to remember that total peripheral resistance has nothing to do with the resistance or the compliance, you should think of the venous system. When you have an increase in total peripheral resistance, you have a decrease in blood that proceeds through the capillary bed to the venous system, and thus you have a decrease in venous return. So in this situation, we see a decrease in both cardiac output and venous return, but we do not see a change in our mean arterial pressure. This is because the total peripheral resistance compensates for the decrease in cardiac output when we think about our mean arterial pressure equals cardiac output times TPR equation. When we increase our TPR, total peripheral resistance, our cardiac output subsequently goes down in a state of homeostasis, and our mean arterial pressure stays roughly the same. So in situations where we decrease our total peripheral resistance, we see an increase in our cardiac output, as well as an increase in our venous return. Now, what sorts of situations do we see a decrease in total peripheral resistance? Well, there's a couple important and high-yield situations, particularly in exercise. When we exercise, we see a decrease in total peripheral resistance because we have local vasodilation in all of our muscle beds to increase blood flow to, say, our quads and hamstrings when we're running, and as a result we get a decrease in systemic total peripheral resistance. Another situation in which we see a decrease in total peripheral resistance is in an arteriovenous shunt. Let's take a moment to think about arteriovenous shunts or malformations and discuss why they might decrease our total peripheral resistance. So here we have a arterio or artery to venous shunt. It's important to know that in these malformations or these shunts created by our vascular surgeons, the vessels actually bypass arteriolar and capillary network. As such, there's no resistance being generated by the arterioles, so we see a decrease in our TPR, total peripheral resistance. So without the arterioles that are responsible for increasing our total peripheral resistance, we reduce our total peripheral resistance, reducing the afterload that our heart is pumping against, and increasing our cardiac output. This increase in cardiac output causes an increase in this cardiac function curve, as well as increasing our venous return. Thus, we have a cardiac equilibrium here as a much higher cardiac output, and we can see that our heart is functioning at a much greater capacity at this situation.